Paracetamol acetaminophen is the most commonly used drug in the world, with a long record of use in acute and chronic pain. In recent years, the benefits of paracetamol use in chronic conditions has been questioned, notably in the areas of osteoarthritis and lower back pain. Over the same period, concerns over the long-term adverse effects of paracetamol use have increased, initially in the field of hypertension, but more recently in other areas as well. The evidence base for the adverse effects of chronic paracetamol use consists of many cohort and observational studies, with few randomized controlled trials. Many keywords of acetaminophen, adverse effects, asthma, gastrointestinal bleeding, hypertension, kidney disease. Paracetamol is currently marketed as an analgesic and antipyretic to be used for no more than 3 days without consulting a doctor. However, due in part to its inclusion in the WHO analgesic ladder, as well as decades of clinical experience, it is also prescribed in chronic conditions such as osteoarthritis and lower back pain. Recently, meta-analyses of the randomized controlled trials assessing covering these conditions have shown the effect sizes to be modest, although still statistically significant, compared with placebo averaging a 4-5 reduction in pain in 9, 10, 11, 12. Despite this, paracetamol has less of an analgesic effect in chronic use than previously thought. There needs to be greater emphasis on accurately determining the harms of long-term use at therapeutic doses. This helps clinicians to balance harms against likely benefits for individual patients and allows regulators to make recommendations on its availability in preparations. The acute effects of paracetamol ingestion and overdose are well known. Harms with long-term therapeutic use are less clear. Concerns have been raised over the effects on the cardiovascular, respiratory, renal, gastrointestinal, and central nervous systems, as well as potential. The present review summarizes our understanding of the evidence on the adverse effects of paracetamol and long-term therapeutic use, informs clinicians of the risks, and provides a clearer picture of the underpinning evidence base. This will, in turn, allow clinicians to discuss with their patients the relative benefits and harms of long-term paracetamol use. We conducted a literature search of PubMed, searching the years 1980 to 2016. An initial PubMed review of paracetamol title or acetaminophen title with side effects or adverse effects revealed several key interest areas, which were subsequently searched for specifically as follows. We combined paracetamol title or acetaminophen title with a hypertension or blood pressure or myocardial infarction or cardiac or cardiovascular stroke or vis or cerebus frauds or an accidental liver or hepatic or transaminase or aminophotnersia or gastrointestinal or bleeding or anemia or renal or kidney or chronic kidney disease or respiratory or asthma. Studies examining the effect of paracetamol on the incidence of cardiovascular disease are relatively sparse when compared to those on SANES 27. Early studies focused on hypertension, which we have reviewed previously 28, owing to the known association of SANES with hypertension and the similar mechanism of action of paracetamol 29. One such study was a placebo-controlled crossover study of 20 treated hypertensive patients in whom a firm rise in blood pressure of BPO was found when paracetamol was administered 30. Given that a 2 rise in systolic BP is associated with a 7 increase in the risk of a stroke. However, observational and interventional studies examining the effect of paracetamol on hypertension have produced conflicting results. 28. To date, most 32, 33, 34, but not all 35, 36 observational studies suggest that long-term paracetamol use increases the risk of developing hypertension. The Nurses' Health study, which included 80-20 participants, found that regular SANE or paracetamol use was associated with an increased risk of developing hypertension. 33. The relative risk of developing hypertension on SANES was 1.8695 confident. By contrast, a retrospective observational study by Dawson et al. 36, with propensity matching, found no impact of paracetamol on BP in a cohort of 2750 for participants with treated hypertension. Although observational studies may find an association between paracetamol use and hypertension, underlying confounders such as chronic inflammatory conditions need to be considered. Unfortunately, to date, interventional studies examining the impact of paracetamol on BP have been limited by study design and small sample size. One recent study by Sedano et al. After aspirin was recognized to cause the rare but serious complication of Ray's syndrome, its use was banned in children under 12 years of age 41. As aspirin use as an antipyretic waned in developed countries and paracetamol use became more common 42, concerns over paracetamol's association with asthma were raised 43. Observational and cross-sectional studies demonstrated a connection between paracetamol use and asthma diagnoses or exacerbations 44, 45, 46. 47, 48, 49, 50, 51. However, a link between paracetamol use and asthma is biologically plausible. Paracetamol metabolism involves the antioxidant glutathione, which is depleted when large doses of paracetamol are taken. There are papers describing glutathione depletion at therapeutic doses of paracetamol 58, 59, and increased oxidative stress could contribute towards either the development of asthma or inflammatory exacerbations in aesthetics 60, 61, 62, 63, 64. Glutathione depletion may also change the helper THO physiology towards a TOIDO phenotype, which is associated with atopic disease. A few researchers have attempted to study the effects of paracetamol on asthmatic patients, adult and pediatric, and sex. Anides et al. 70 randomized adults with mild to moderate asthma to placebo or paracetamol for GD1 for 12 weeks, then submitted them to http with guided tempranodically or graclagendorfildorligandid 7000 for 138 challenge test. Airway hyperepsinescence was similar in both groups. Amount of methylation required to reduce FEVN by 20. Paracetamol group of placebo was a 0.48 mg/ml 95 C 1.28. Overall, there is evidence of a weak association of paracetamol use with asthma, but causation cannot be established. Effects are limited, but seem to provide reassurance that paracetamol is safe to use in patients with established asthma 70, 71, 72. Astringent AGIO effects. The acute effects on the liver of paracetamol and overdose have been well documented 73, 74, 75. However, the effect of chronic therapeutic dose paracetamol use on the liver and the system in general is less clear. Concerns are generally focused around deep blood loss and chronic hepatitis. Deep bleeding. Paracetamol has long been considered the safe analgesic alternative to SANs in patients prone to deep bleeding. Indeed, in studies of the analgesic effects of SANs, it is commonly used as a comparator, owing to the ethical issues of withholding analgesia 76, 77, 78. There is some evidence to support the safety of paracetamol. Examining adverse events reported in the Spanish drug monitoring system, Carvajal et al. 79 found that paracetamol use was associated with nausea 3.3 of all reported adverse events and dyspepsia 4.2, but not deep bleeding. However, recent epidemiological studies have identified a potential increased risk of upper deep bleeding with doses of paracetamol to 3-GD1. In 2001, the case of control study was conducted using the General Practice Research Database UPRIDA 81. Adults aged 40-79 years with no history of prior GI disease or alcohol misuse and 13,605 were followed up between 1993 and 1998. The incidence of upper GI complications was documented, as was the prescription of paracetamol and potentially confounding medications, compared with known users of paracetamol. In 2008, a study of GI-related hospitalization in elderly patients in Quebec examined the effect of SANs, paracetamol 3-GD1, paracetamol 3-GD1, and proton pump inhibitors of PO83. Using paracetamol 3-GD1 as the reference population, they found hazard ratios of HRSA for GI-related hospitalization of 1.2 to 95 C 1.3 to 1.40 for paracetamol 3-GD1, 1.63 and 95 C 1.44 to 1.85 for SAND, and to 0.55 and 95 C 1.98. Early sects in this area appeared to give reassuring results. One crossover study examining the effects of 7 days of paracetamol, http with guided tempranodically or graclagendorfildorligandid for 1,795 or placebo on endoscopic appearances found no acute effects of paracetamol on the GI mucosa 84. However, more recent sects have been less reassuring. In 2011, Doherty et al. 76 examined the effects of paracetamol, 3-GD10, ibuprofen 1200 mg/d10, and a combination of the two ibuprofen 600 mg paracetamol. Based on these data, it seems that when taken regularly at doses of 2-3-GD1, i.e., at daily doses normally seen in chronic use, there is a significant risk of deep bleeding with paracetamol. The dose-response relationship seen in some of the studies would indicate that something in the mechanism of action of paracetamol can cause deep bleeding as an adverse effect, and that this effect is additive when combined with SANES. Hepatocytosis. Over the past few decades, there have been several case reports and small studies implying the connection between the ingestion of therapeutic doses of paracetamol and liver injury 86. It has been known for many years that therapeutic paracetamol use for GD1 has been associated with subclinical rises in liver injury markers 74. However, transient rises in alanine aminophosphorus can be secondary to many factors such as exercise, vitamin intake, congestive heart failure, diabetes, and medications such as aspirin, heparins, and statins 87, 88. Whether such an enzyme rise results of those case reports of liver injury in patients taking therapeutic doses. Additional factors such as alcohol abuse, nutritional deficiency, or concurrent febrile illness are usually present. 91. As the toxic metabolite of paracetamol naphtha is produced by CYP metabolism, predominantly the HTTP with guidetemphranodically or GRAC objected after objected 1330 isoniazumide. Clinicians have hypothesized that induction of these enzymes through alcohol misuse might predispose patients to liver injury. This appeared to be supported by animal studies showing that cypwino was induced by ethanol in rodents, and that hepatocytosis in children. Children metabolize paracetamol differently to adults 100, and there is some concern that they may also suffer as a result of ingestion of therapeutic doses of paracetamol. This prompted Lavonis et al. 87 to perform a systematic review in 2010, examining 60 studies and 30 children receiving therapeutic dose paracetamol 75 and KH1D1 up to maximum of for GD1 for an average of 3-5 days. The range of settings when patient, outpatient, primary care, developed and developing world on indications for paracetamol infective illness, post renal effects. Acute kidney injury is said to occur in 1 to of patients in paracetamol overdose 101 and most commonly occurs in the setting of severe paracetamol-induced hepatocytosis 102. Analgesic nephropathy is characterized by interstitial nephritis and progressive reduction in renal size due to repeated episodes of papillary necrosis. The association between the analgesic phenacin and nephropathy was first described in 1953 106. And by the 1970s, analgesic nephropathy was reported to be responsible for at least 10 to 20 of cases of chronic renal failure in the UK and Australia 106. Despite phenacin's withdrawal from sale in the 1980s, analgesic nephropathy has not been eradicated, suggesting that other agents may also be responsible. 107. Pregnancy. Paracetamol is administered to pregnant women as an antipyretic agent and for the management of mild to moderate pain. The presumed safety of this agent has resulted in paracetamol becoming one of the most common prescriptions in pregnancy. 50-60 of pregnant women in North and Western Europe self-report using this medication. 112. Its popularity is mainly due to the recommendation of paracetamol over other analgesics, with SANES having a less favorable risk profile in pregnant women, and use of aspirin limited due to concerns over its effect on the fetus. 113, 114. In recent years, the safety of paracetamol in pregnancy has come under increasing scrutiny. Paracetamol and its metabolites cross the placenta 115 and undergo different pharmacokinetic and pharmacokinetic processes in neonates than in adults. An immature glucuronide conjugation system makes the sulfation pathway the major route of metabolism in neonates. 116. Paracetamol has been postulated to cause a diverse range of embryo-fetal and neonatal adverse effects, dependent on dose, duration of treatment, and the trimester of exposure. However, large cohort studies have not found an association. Neurodevelopmental effects. The association between paracetamol exposure in utero and the risk of long-term neurological disorders has been the focus of several controversial pharmacoepidemiological studies. Brandleston et al. 119 suggested that maternal paracetamol use for 28 days during pregnancy was associated with problems in gross motor development, communication, externalizing and internalizing behavior, and higher activity levels when compared with controls. These data were obtained from a Norwegian sibling-controlled study then 2919 and based on parental reports of child behavior at 18 months and 30. Maternal paracetamol use was later linked to a nordelafiontal clinical outcome in the Danish National Cohort Study. Liu et al. 120 suggested that maternal paracetamol use during pregnancy was associated with a higher risk of receiving a hospital diagnosis of hyperkinetic disorder HR 1.37, 95 C 1.19 to 1.59, use of attention deficit hyperactivity disorder ADHD of medications HR 1.29, 95 C 1.15 to 1.44 or having ADHD-like behaviors at age 7 years HR 1.13, 95. The mechanism by which paracetamol and its metabolites may affect neurological development is poorly understood. Animal studies have reported behavioral and cognitive changes in mice given paracetamol during neonatal brain development, specifically locomotor activity and attainment of spatial learning. 123. Levels of HTTP with guidetemphronautically or grachlagendorfelderliganded for 1,872 addenda in the neonatal brain were affected as significantly increased in the frontal and decreased in the parietal cortices, postulating that this may be the mechanism of action. The role of DEND in development and in conclusion, on the basis of these studies, only weak associations between paracetamol exposure and neurodevelopmental issues have been identified, and no causal link can be inferred. The epidemiological studies that support a link are subject to confounding by unmeasured environmental factors, recall bias, diagnostic inaccuracy, and most rely on coding data or parental recall for their outcomes and differences in dropout rates. Notably, few studies confirm the effect of duration and timing of paracetamol exposure, details that are critical in the assessment of toxicological risk in pregnancy. Asthma. The potential mechanisms by which paracetamol may contribute to the development and exacerbation of asthma have been described earlier. How paracetamol exposure in utero could cause asthma is less clear, unless glutathione levels are lowered sufficiently in the fetus to affect lung development. Some support for maternal intake of paracetamol affecting offspring comes from mouse studies, where adult mice exposed to paracetamol in utero underwent an allergic airway challenge. 125. Increased airway infiltration by leukocytes and notably eosinophils was observed, suggesting an increased susceptibility to asthma, but this finding has not. The Avon longitudinal study of parents and children was one of the first epidemiological studies to examine the causal link between paracetamol exposure during pregnancy and childhood asthma. 127. Frequent paracetamol use in late pregnancy at 20-32 weeks was associated with an increased risk of wheezing in the offspring at 30-42 months adjusted or to 0.10, 95 C 1.30 to 3.41, particularly if wheezing started before 6 months earned a persistent wheezers or to 0.34, 95 C 1.24 to 4.40. To further however, maternal infections, including respiratory infections, have already been associated with an increase in childhood asthma. 130, 131. Paracetamol use may simply be a surrogate for these disease states. Notably, maternal paracetamol use for non-infectious disorders revealed no increased risk of wheezing in children. 132. Further studies expanded on this theme of confounding by paracetamol indication and have highlighted that the increased risk of asthma diagnosis in children exposed to paracetamol prenatally when adjusted or 1.36, 95 C1. Endocrine and reproductive toxicity. The incidence of cryptogrammus is reportedly increasing, which is particularly concerning given its association with early adulthood disorders such as low sperm count and testicular germ cell cancers. 134. When considered together, these conditions represent a testicular dysgenesis syndrome, a disorder related to androgen disruption during the fetal programming window. 135. Experimental data have shown reduced testicular PGF and HTTP with guidetemphronautically or grachlagendorfelderliganded 2858 production and reduced endogenital distance, a marker for androgen action in rats. Several clinical studies associate paracetamol exposure during pregnancy with increased occurrence of cryptogrammus, particularly when used in 4 to weeks in the second trimester. 136, 139, 140. Few of these studies considered indication for paracetamol use in their analysis, and laterally, reanalysis of these data sets showed slightly lower HERs for paracetamol exposure during weeks 8 to 14 among women who did not report an illness that would trigger weak analgesic use 141. This is an interesting paradoxical observation, given that this time frame represents the continuing search for evidence that paracetamol causes harm in pregnancy. Clearly highlights the difficulty in implying causation from pharmacoepidemiological studies. Extrapolation of preclinical toxicology data to humans may suggest associations with asthma, ADHD, and androgen disruption, but the small associations seen in clinical cohort studies may be explained by various confounders and biases inherent in the study designs. Confidently teasing apart these issues would require sects, which would be difficult to perform ethically in pregnant populations. Carefully designed long-term, sibling-bound sex match discussion. Clearly, there remains considerable uncertainty regarding the chronic adverse effects of paracetamol use. The evidence base in each of the above sections relies mostly on observational and cohort studies, and so is prone to inherent biases. The positive associations found in these studies are generally weak and often contradictory. Few sects have been performed, but when undertaken, usually give reassuring results. Further studies are required in many areas, but sects may be difficult to perform, either because they would need to be very large to detect the modest increases in risk seen in the observational studies. The two areas in which the evidence is most convincing are hypertension and deep bleeding. A small BP rise of from FJN would be clinically important at the population level, and the outcome of ongoing sects should clarify the reliability of this estimate. This may be particularly important in patients with angina or pre-existing hypertension. The fairly consistent evidence for deep bleeding associated with paracetamol use, along with its additive effect when combined with SANES, may be less well known but similarly important. When considering prescribing paracetamol in the chronic setting, it would seem wise to consider these adverse effects. Whether paracetamol use in the chronic setting should be restricted is doubtful, given that the alternatives are SANES and opioids. Indeed, in patients intolerant of SANES, their next option would be opioid medication, which comes with risks of addiction, drowsiness, and fatal accidental overdose. In summary, the average therapeutic effect for chronic pain syndromes is small, but there is accumulating evidence of clinically significant adverse effects in chronic use. Despite this, for patients who derive clear symptomatic benefit or only take occasional therapeutic doses, the risks are probably very small. For this reason, paracetamol can be seen as the least worst option, which probably means that it will remain, for now at least, the first-line analgesic of choice. Conclusion. The present review is designed to provide an objective summary of the evidence base for chronic adverse effects of paracetamol use. We hope that by highlighting the key epidemiological studies, sects, meta-analyses, and reviews, we have provided a valuable summary of knowledge in this field. We hope this work will help clinicians and their patients to make an evidence-based, informed decision regarding their chronic pain management based on the likelihood of clinically relevant adverse effects. Nomenclature of targets and ligands. Key protein targets and ligands in this article are hyperlinked to corresponding entries in http guidetemphranautically.org, the common portal for data from the UPharPS Guide to Pharmacology 150, and are permanently archived in the Concise Guide to Pharmacology. Panadol is one of the world's most trusted pain relief brands, containing paracetamol, used in over 80 different countries and regions globally. Every day, when pain strikes, millions of adults reach for Panadol to help free them from pain, thanks to the effective relief that Panadol provides. Learn more about Panadol today. How does Panadol work? Panadol is an over-the-counter pain relief medication that provides effective temporary relief from pain and discomfort associated with many different common conditions, including headache, muscular aches including back pain, period pain, toothache, flu symptoms. Panadol can also help to reduce fever when you're suffering from a high temperature. The active ingredient in Panadol is paracetamol, a common pain reliever. Read on to discover everything else you need to know about Panadol for adults in this simple guide, where we will address commonly asked questions about Panadol, including the right dosage of Panadol to take, whether it's possible to take Panadol with other medication, Side effects and how to use Panadol correctly. Using Panadol for adults of frequently asked questions. What dosage of Panadol should I take? If you're suffering from mild to moderate pain, Panadol gives you pain relief. Panadol products for adults come in tablets and soluble tablets. For dosage information, see product pages or label. If you are at all uncertain about the correct dosage of Panadol to take, consult your doctor or pharmacist before use. You should also always read both the dosage instructions and any warnings on the product label leaflet before using any Panadol product, so that you are aware of any potential side effects or risk of overdose. Can you use Panadol during pregnancy and when breastfeeding? You should consult your doctor before taking any medicine. Your doctor is the best person to advise you on whether using Panadol during pregnancy is safe for you, how often you should take it if at all, and what side effects you may be at risk of experiencing. Panadol Extra film-coated tablets and Panadol Extra 500 mg 65 mg soluble effervescent tablets are not recommended during pregnancy or breastfeeding, unless recommended by your doctor. Panadol night tablets should not be taken when you are pregnant or breastfeeding unless your doctor tells you to. Can you use Panadol with other medication? You should always consult your doctor or pharmacist before using Panadol and any other medication together, to make sure it is okay for you to do so. Do not use Panadol with any other paracetamol-containing products. Taking two paracetamol-based medications together could put you at risk of a paracetamol overdose. Always check the ingredients listed on the product label of any medication that you plan to take with Panadol before use. Learn more about combining Panadol with other medications on our page below. Can you take Panadol on an empty stomach? Yes, Panadol can be taken with or without food. Can I take Panadol if I have COVID-19? Yes, paracetamol is recommended by healthcare professionals to help reduce symptoms of pain and fever related to COVID-19. Paracetamol is the active ingredient in Panadol. Can I take Panadol after COVID-19 vaccination? Yes, paracetamol can help reduce symptoms of pain and fever post-COVID-19 vaccination. Paracetamol is the active ingredient in Panadol. Can I use Panadol with other medicines or drugs? Unsure about whether you can use Panadol with other medicines? Learn more about using Panadol and other common medications at the same time with our simple guide. Can I use paracetamol and ibuprofen together? Paracetamol and ibuprofen are both common over-the-counter auto pain relief medicines, but they act in different ways and are different ingredients. The main, or active ingredient in Panadol is paracetamol, which is a simple pain reliever. It's used for treating mild to moderate aches and pains such as headache, backache, cold and flu symptoms, or toothache or muscle pain, as well as for helping to reduce fever. Ibuprofen is a non-steroidal anti-inflammatory drug. This means that it can help to reduce inflammation as well as ease pain, so it's used for treating conditions that may cause some swelling or inflammation such as pain associated with non-serious arthritis or periods. So, can you use ibuprofen and paracetamol at the same time? Put simply, yes. If you are over the age of 16, it is generally considered okay to take medicines containing ibuprofen and paracetamol simultaneously. In fact, research suggests that using Panadol and an ibuprofen-containing drug together may even provide more effective relief for some types of pain than only using one of the two medicines. Please read the leaflets to check if your specific circumstances health condition would be okay to take the two ingredients together. If you are unsure, you should talk to a health professional like a pharmacist. However, it's important to note that using paracetamol and ibuprofen together is not recommended for children, unless advised by a healthcare professional. If you are in doubt about whether or not you should use a combination of Panadol or paracetamol and ibuprofen or any other medicine to treat your pain, speak to your doctor or pharmacist. They are best equipped to advise you on the potential risks or side effects of using Panadol with another medicine. Always read the dosage instructions on the product label before using Panadol or any other medication. Get relief from everyday pain with Panadol. Discover the full range of Panadol everyday pain relief products today and find out which one could be right for you. Types of pain relief medicines at a glance. Paracetamol, aspirin, relieve pain and reduce fever. SANES, relieve pain, reduce fever, and ease inflammation. Codeine, or prescription. Man meditating. Can I combine Panadol with other SANES? In many cases, using Panadol or paracetamol together with other anti-inflammatory pain relief medications, including ibuprofen, is okay when both medications are only used at the recommended dose as per the instructions on the product label, unless otherwise specified by your doctor or pharmacist. For example, in many cases, Panadol may be used in combination with the following SANES: Voltarol Amyval Extra Strength, WW gel, a topical gel for joint and muscle pain relief. The active ingredient in Voltarol is diclofenac diaminamol, unseen that is